The problem is we miss a lot of diagnoses. In this case, nothing is evident, and if the patient comes in with absolutely no symptoms, what we're going to do is we're going to miss the fact that he has a fractured tooth. This is a cone beam image of the same tooth. And if you can see the fracture and there is no symptomology with the patient, you simply show them the picture. They can see the fracture as clearly as you can. It stimulates the patient to get something done, or to, at the very least, to be educated and to ask questions about their condition. So I took an example case of a gentleman that came into our office just last week. Another thing we see are fractures in teeth. That upper left bicuspid has a, upper right bicuspid has a fracture in it that goes down to the crest through the tooth. And these things are hardly ever visible on a PA. How about the presence or the length of a canal? I know a lot of people use what we call apex locators to do endodontics. But a lot of times in using that locator, we're a little concerned whether it's accurate or not. If we pre-measure the canal on the cone beam, because the cone beam is accurate to within 1/10 of a millimeter, then we verify with the apex locator, then that will tell us that the apex locator is working, and we now have two ways of verifying the length of a canal. The other thing is, let's look at the MB2 canal on an upper first molar. And if we can identify the presence or absence of that, it allows us to approach the tooth endodontically with greater success. Sometimes endodontic lesions will occur, or lesions will occur on a tooth previously treated with endodontics. If you look at the dates on these two films, you'll see that one is 2012 and one is 2017. In 2012, this patient reported no pain and no symptoms, even though we found a lesion. We showed her the lesion, and she said, I don't want to do anything with it. I'm just going to leave it alone. 5 years later, she came in. We took another cone beam, and this time the lesion measured quite a bit larger, not quite twice as big, but from 4 to 7 millimeters. I didn't tell her she had to do anything, just like I didn't tell her the first time. But what I did do is I said, now that we've measured it and it has grown, do you want to continue to watch it? Interestingly enough, even though it still had not developed any symptoms, she decided to go ahead and get some treatment done. Periodontal lesions are easy to see if they're on the mesial or distal, but on the lingual or buccal, much harder. And this helps the clinician's diagnostic abilities, plus it helps them to educate the patient to see exactly what's going on. We can take TMJ film. You can take them in 3 planes: axial, sagittal, coronal. You can take them in a bite open position or a bite closed position, or you can take them with an appliance in place. Airways are getting a lot of attention nowadays.